So next topic we'll discuss short topics of trigeminal neuralgia. In this, we'll discuss what we can do in our clinical practice at all. See, all the topics they have different medicinal managements and different hospital managements. What we can do in our clinic, how can we diagnose the situation, or how can we do medicinal treatment, or how can we do short surgical procedures in our clinic, that we have to discuss. Okay. So basically, it is paroxysmal episodes of sudden, usually unilateral, severe recurrent pain of searing, stabbing, and lancinating type in the distribution of one or more branches of fifth cranial nerve, accompanied by the spasmodic contraction of facial muscle, often initiated with a trigger zone. So this was the main vision of the trigeminal neuralgia. And this one is painful unilateral flexion of the face characterized by belief electric shock like pain. So the pain is severe stabbing and lancinating type. Okay, so it can be aggravated while shaving, smoking, talking, brushing of teeth, including washing face, and it can occur at any time and spontaneously. The proximal nature of the trigeminal neuralgia was probably a result of the abnormal conduction of the nerve. Therefore, the disease is known as neuralgia epileptiform. Under special circumstances, the impulse from the one nerve fiber can short circuit into the adjacent fiber of like size, creating a sort of artificial synapse. Experimentally, they are demonstrated as the stimulation of type C affected efferent fibers could stimulate an adjacent efferent types and C fiber, resulting in a condition referred to as a cross-top or back top. The trigeminal neuralgia to be the secondary to the dental disease. Many lesions such as epidermiform tumors, meningiomas of cerebellopontine angle and Meckel's cave, then arteriovenous malformation, aneurysms, vascular compressions have since been discovered as a cause of typical trigeminal neuralgia. Such of the reasons are found in surgical correction of generally cures the neuralgia. The tick caused by such tumors in the indistinguishable form, typically tick even in such patients have trigger zones and pain cycles. The compression of intracranial and retrogastrian portion of the fifth cranial nerve by displace the artery of vein, and the patient will feel the partial action of the displaced vessel caused by the abnormal discharge of nerve later. So these are all the etiological factors and how it is going about. This is all that the vascular compression of the fifth cranial nerve is often produced by the pain of typical trigeminal neuralgia. Tumors of posterior fossa, one of the reasons that cause acoustic neuromas or the trigeminal neuromas are unusual causes of the trigeminal neuralgia. Sclerosis have a higher incidence of trigeminal neuralgia pathologically, and sclerotic plaque has been found at the root of entry zone of the fifth cranial nerve. The anomaly of superior cerebral artery, then vascular factors, post-herpetic neuralgia is also included sometimes. In clinical feature, pain is characteristically paroxysmal, lasting from few seconds to minutes. It is just like an episode. Okay, it is extreme in intensity, described like a knife-like sharp or like a bolt of lightning. Even though there is no pain between the attacks, and patient of frequently complain of facial soreness. Some patients, when questioned, may give the impression that last attack lasts longer than the few seconds, but more careful questioning usually discloses the fact that the patient was experienced a rapid series of shock-like pains rather than the constant pain, and pain rarely crosses the midline. The majority of patients will have one or two more trigger points. These cutaneous zones are located in the terminal distribution of one or more with a major trigeminal division. The stimulation will elect severe lancinating pain. The stimulus may consist of touching the area, talking, chewing, charring the body, or even blowing off the light breeze with a trigger. Like just like feather-like touch can also trigger. So there are sensitive periods. The pain may be active for several days or weeks, and then subside for several months or several years also, especially during the early period of onset. The pain is confined to the area of cutaneous innervations of fifth cranial nerve, but there can be a significant variability in the cutaneous innervation by this nerve. The pain affects only on the side of face at a time, and even in bilateral trigeminal neuralgia, sometimes the pain may strike on one side of the face on one occasion. Means for bilateral trigeminal neuralgia, there might not be the episodes, they come at the same time. Okay, so patient undergo discrimination of dental extraction. One of my patient came and he had got down his all this side of mandibular teeth extracted by some other dentist in United Kingdom in London. So when he came to me, it was diagnosed as trigeminal neuralgia, and with medicinal treatment he got cured. In trigeminal neuralgia generally occurs during late middle age or later, and it's more common in females. The sex ratio was found to be female is 1:1.7. The spontaneous remission are unusual, and in most cases paroxysmal occurs in the cycles, appear to closer and closer together. With each attack, pain seems to become more and more unbearable. It is a characteristic of the disorders that attacks do not occur during sleep. So V2, V3 division of trigeminal neuralgia nerve are involved most often and with equal frequency. 0.5 ophthalmic division rarely involved in 1 to 5% of cases. Some investigators have attempted to explain the basis of embryological observation that V1 is separated on the origin from V2 and V3. So most common in V2 and V3. Location of the trigger zone depend on which division of the trigeminal nerve is involved. The trigger points is usually at the terminal distribution of the uninvolved division that are not in the broader zone. So if the involvement of division V2 is, the trigger point may be located in the skin or the gum hair. Touching with the teeth palate rarely produces a pain. So usually V3 division is involved this area. So tongue is very rarely the source of pain. Diagnostic criteria of trigeminal neuralgia is the pain is paroxysmal. The pain may be provoked by a light touch even. The pain is confined to the trigeminal distribution. The pain is unilateral. Pain is sensory examination is normal. If the patient's pain fails to meet any of the 5 foregoing criteria, the diagnosis is idiopathic. Diagnostic testing, periapical or panoramic radiography may have helpful in the evaluation of the dental-alveolar structures and the region of pain attacks, because the significant percentage of patient symptomatic trigeminal resulting from the another disease process. Diagnostic brain imaging studies should be a part of initial evaluation of the patient with trigeminal neuralgia symptoms. The most effective technique so far for detecting an intracranial lesion is magnetic resonance imaging, or commonly known as MRI. Diagnostic blocks can be given. Yes, if the patient is having pain or trigger zone here, you can give a diagnostic block. Okay, then ask if the symptom subsides, or if the symptoms it came in before your eyes, then you can give a diagnostic block. If the patient's symptoms subside, then you can see there's a peripheral peripheral trigeminal neuralgia. Then you can go with neuroptomy procedures also. So differential diagnoses are atypical trigeminal neuralgia, cluster tick symptoms, hemifacial spasm, post-herpetic neuralgia, and other cranial neuralgias. Treatment is medical, surgical, central and peripheral, destructive and non-destructive. In medicinal treatment, carbamazepine 100 mg TID is introduced and it can be increased up to 600 mg. The side effects are visual blurring, dizziness, skin rashes, ataxia, leukopenia, and thrombocytopenia. If remission occurs, dose can be reduced and kept in maintenance dose and increased if the symptoms appear again. Drugs given in the combination of carbamazepine are sodium valproate, then phenytoin, gabapentin, and lamotrigine. Other drugs are clonazepam, then phenytoin, oxycarbamazepine, and tablet valproic acid. Surgical treatment is for central alcohol blockage of Gasserian ganglion, then radiofrequency at Gasserian ganglion, retrogastrian rhizectomy, medullary tractectomy with the help of Dandy's approach and all midbrain tractectomy, intracranial nerve decompression. See, these Geneta approach and Dandy's approach, they can be done in your clinical setup. Okay, you need a higher centers for that. In clinical setup, peripheral neuroptomy can be done. Alcohol blocks in peripheral nerve can be given. Then supraorbital neuroptomy can be done here. Then infraorbital neuroptomy can be done easily. That can be done intraorally. After retracting the gingiva, okay. First give a block, then infraorbital block, then retracting the gingiva, pull, identify the foramen, pull the nerve, take a round forward, and then after pulling the nerve, you can cauterize the remaining nerve. After that, that foramina has to be blocked. So you can use a titanium screw for that, small screw, which are used for plating, and you can block the foramen. Or you can block it with a bone graft also. In inferior alveolar approach, you have to open this area, retromandibular area, and then retromandibular area is open, and then it can be done with then inferior alveolar approach. It is also known as Ginwala's technique. And next is electrosurgery, cryosurgeries, and selective radiofrequency and thermocoagulations. Other approach are acupuncture, biofeeding feedback, and then counseling. So this ends our Trigeminal Neuralgia. Okay. So next we'll have a small topic of antibiotics, and then proceed to the perio part of the oral surgery.